Guys, all these days, listen carefully. I have been teaching and you have been listening and answering both the ways. But, always classes should not be one-sided. You should get a chance to think. I want you all to put in the knowledge today from all the classes that we have covered. You can open your syllabus copy. I have covered you with basics. I've covered you with staging. I've told you about adverse effects. I told about many things. I told you some concepts. All these things will put together and you will have to apply all your knowledge and skills today. Are you all ready for the interactive class today? Type me in the chat box yes or no. Because what all the information I have given you in one or the other form, you will be able to find out in Google. Okay, yes or no? I have compiled stuff and I've explained you in a easier and simpler way. But you will not have a class wherein which you will get to put all your knowledge and skills and apply in a patient. Okay? Today, you are going to apply all the knowledge and skills to apply in a patient, and then you will intervene the stuff and we will discuss it. That's how we will finish the topic supportive care in oncology. Okay? Are you all ready? I will call out the names and we will start the class. If you all type me in the chat box exactly 7:5, we will start. Yes or no? Yes? Everyone? Okay, guys. I'll share you because you need some PPT. I'll share you with the PPT. Okay, we have seen different grades of toxicity. Now I'll call upon the names. Two of you will unmute yours. This thing. Dr. Pranav Upadhyaya and Shagufta. Unmute your mics.
Yes, ma'am.
Yes, ma'am.
Okay. You have attended all my classes, right?
Yes, ma'am.
All
Yes,
of
ma'am.
you all want this class, right?
Yes, ma'am.
Yes. Okay.
Yes, ma'am.
Carefully listen. I have told you, I've given you that I told you to read about few drugs, every one of you, right? Irrespective of whichever cancer it is, you will use some type of among all the treatment options, you will use chemotherapy, immunotherapy, or targeted therapy, or whichever anti-cancer drugs use, you will have side effects. Okay? What is the misconception that you will think, okay, this drug has this side effects, this drug has this side effects. This is how we have been trained to read pharmacology. Yes or no? One of you? Shagufta, tell me, yes or no?
Yes, ma'am.
But have you ever read this adverse effect will be severe in this case? It will become more synergistic. You would have read by addition of the other drug, the adverse effect may become synergistic. Yes or no? Yes? When two drugs are given with similar side effects, the side effect, it will increase, right? The intensity will increase. It is not only when you give two different drugs. Always remember that Even in case of cancer, certain kind of cancers will have certain kind of adverse effects, severity with that drug, it will increase. Okay. I will tell you an example. All of you heard of cisplatin? I want everybody to reply for this. All of you have heard of cisplatin?
Yes, ma'am.
So, if I tell you cisplatin and if I tell you nausea and vomiting, you going where you will check, there's something called as predictability, preventability of ADR. Have you heard of it? If you have not heard, I will send you one Hartwig. I'll send you some scales, okay? I don't know if I've sent you before or not in the group. Yeah, you can open the group, man. There is a ADR assessment causality scales are there. You can find that criteria for determining predictability of an ADR. Have you all opened? If you have opened, there you will see something called as patients who have never had the drug previously. See, all the cancer patients. So, all our patients are coming for the first cycle. Please carefully listen. This is how you have to analyze the patient. So, all the patients are coming for the first time and you are giving the drug for the first time to a patient. So, you guys don't know how the patient is going to have what kind of adverse effects, to what severity the patient will have side effects or will not have side effects at all, or else how much will the patient tolerate the treatment. Did you understand till here? You don't know anything. Everything is a question. And you cannot tell the patient you will have these adverse effects. You will not be able to tell you will face this. You are in a position that you don't know what will happen to a patient. But you know when you give certain drugs, what can happen with the use of the drugs. How will you know that? See there, incidence of the adverse drug reaction reported in product information or other literature determines its predictability. So you can see where do you get these incidence rates? Okay, when you open Medscape or Micromedics, in the brackets you will find okay greater than 10%, greater than 1% and less than 10%. So you'll see very common, common, uncommon, rare and very rare. Kindly go and open cisplatin in your Medscape or Micromedics. Do you guys have that? Please do open and tell me what is the percentage of nausea and vomiting for cisplatin. Come on, answer me. Open cisplatin, open ADR. See in brackets, something will be there 100%, 99%.
More than 10%.
Go and see there. 76 to 100. Correct. So it is usually 100 you will find in Micromedics or Medscape. Okay, 100 means all the people who are on cisplatin have the chance of have vomiting. That doesn't mean everybody will have also based on the reports and all. So you can tell the patient. So when you are giving antiemetics, okay, you have to give to a patient highly emetogenic chemotherapy, means something which is acting on your vomiting center in the brain. Okay. And different types of vomiting, acute vomiting, delayed vomiting, all this will be there. So acute means immediately. Because there is a high chance of vomiting for the patient, when you are giving a chemotherapy with cisplatin, you have to give a pre-medication that will stop nausea and vomiting at the level of vomiting center. Okay, that is how you choose a pre-medication to a patient. And you will have to explain the patient about the things that after chemotherapy, what all side effects you can have. One among it is nausea and vomiting. How to manage nausea and vomiting? Next thing. So when you're sending a patient home after chemotherapy, you will have to prescribe antiemetics to a patient for around 5 days, 5 to 7 days. Okay. Usually the medication that will be given will be ondansetron 8 mg TID for 3 to 5 days. And you will tell them SOS for vomiting. Okay, guys. Ma'am, cisplatin is there, vomiting is there, you are telling we will prescribe in discharge medication, we'll do patient counseling, we'll send the patient. Another thing, cisplatin is used in different kind of cancers with different combinations. Okay. Suppose if patient is being treated with cisplatin for head and neck cancer. Okay, Shagufta. Shagufta,
Yes, ma'am.
tell me patient is head and neck cancer.
Okay.
After chemotherapy, other than nausea and vomiting, what will be the additional side effects you could think?
Um,
See, here so many side effects are there. I'll just show you in the PPT. There's so many, right?
okay.
1 second, let me see. Where are these? There's so many side effects of anti-cancer drugs. Vomiting, nausea, electrolyte imbalance, so many are there. Suppose if patient is head and neck cancer, what do you think will be? Tell me. Other than nausea, vomiting, what you can see?
Anorexia is here, ma'am. Anorexia, so.
Okay. In head and neck cancer, the usual treatment protocol will be radiation with chemotherapy. Yes or no? They
Yes,
will
ma'am.
do radiation as primary treatment, and cisplatin is a radiosensitizer used to increase the sensitivity of radiation. Okay. So what will be you will not only have the effects of chemotherapy, but patient is getting radiation. Head and neck means maybe oral cavity, throat, tongue, below the tongue, heart palate, all these areas. Yes or no? And people who are taking radiation will have so much of dehydration. Getting my point? Now, Shagufta, tell me what all other side effects a patient can have. Somewhere the tumor is in oral cavity.
Ma'am, alopecia, ma'am.
Leave about alopecia external. Tell me the patient is having his tumor in oral cavity. So, guys, anybody can respond me in the group. What all side effects? Yes, mucositis, dry mouth. See, because of mucositis, what can happen? Very good, Yash.
Ma'am, candidiasis.
Ulcers, dysphagia. Very good. You all are telling very good. I'm very happy. Come on. What else? So, because of dysphagia, what can happen? Okay, candidiasis also can happen because it is in oral cavity. So, patient is susceptible to fungal infections, but may not be everyone. Because of dysphagia, what will happen? Patient will have, is not eating food properly, then what will happen? Malnutrition, weight loss, very good. What else? Yes. See, now we all come together. Wait, because patient is having tumor in oral cavity, patient may not be able to eat or take oral intake. Because there is no oral intake, there will be weight loss. Because of weight loss, malnutrition, additionally radiation, so much of dehydration, and orally patient will not be able to take fluids. Because of that, patient may have electrolyte imbalance and patient will have nausea, and if it is vomiting, it will more increase. Okay, choking, not everyone, it depends, and some people can take liquids and semi-solids. So how you will educate. So because the patient is taking cisplatin and he is having head and neck cancer, you are finding all these side effects. Okay, suppose you are giving a cisplatin drug to a patient with other cancer. Okay, okay guys, are you understanding? Maybe, in cervical cancer also you will give. In testicular cancer, you will give, that's what, ovarian cancer, you will give, lung cancer, so it is
Ma'am,
you.
we got disconnected because of the power issue, ma'am.
Now you can listen to me, hear
Yeah,
me.
yeah, I can hear, ma'am. I can hear. The power actually went, so my Wi-Fi also went, ma'am. I connected my mobile data now.
Okay, now you are able to hear, right?
Yeah, yes, ma'am. Yes, ma'am.
See, what will happen is, in head and neck cancer, you understood the use of cisplatin, right? But suppose
Uh,
same
yeah,
cisplatin
yes,
is
ma'am.
given in ovarian cancer or some gynecological cancers. Will you feel the same side effects like mucositis and all? There may be a chance, but the intensity of mucositis will be same or different. The chance, prediction,
Ma'am, it may be different, ma'am.
it may be different, right?
Yes, ma'am.
So now you understood someone taking cisplatin with head and neck cancer, how you will have to counsel a patient. Okay, you will tell him, you see some patients who cannot take oral intake, they'll have Riles tube. They'll give high protein food and all to the patient through the pipe because he is not able to consume. So you have to explain the need of Riles tube in case of side effects. You have to tell him when he's having oral cavity, some cancer in oral cavity, you have to explain him about how to manage with all the medications. What is that orally he will have to apply, okay? Sometimes if the ulcer is some ulceration is there, you need numbness, right? Yes or no? You need to make the area numb. For mucositis and all, you will have do some local application, local anesthetic gel will be there. Okay. So tell me yes or no. Tell guys. So when the severity of mucositis is more, then you need some local anesthetic drug to be given to a patient. Something called as xylocaine, like xylocaine viscous something is there, yeah, Jiti gel is for local application. Okay. Sometimes when the severity is high, you need xylocaine viscous, like that syrup. Okay. It is some lidocaine hydrochloride where you will have to gargle in your mouth and need not spit it. Sometimes you will have in the esophagus area and all. So at that time you can take it inside. Some anesthetics or something like that should have to be spit out. In case of xylocaine viscous and all, you can take it inside. So when the patient is having neutropenia, you will have more chance of having more mucositis, and additionally head and neck cancer, you will have more chance. Okay. So depending on, if you have white color, developing small spots, it's a fungal infection. So you will have to give antifungals to a patient depending on whether you need only like Jiti gel or whether you need Zilocaine viscous. You have to rule out what is the cause and then you will have to treat the patient accordingly. Whether you have to see doing it for like for mucositis with candidiasis infection, or where you have only mucositis or just the reddishness, depending on that, you will have to see. And sometimes, B12 and folate also will be less for some patients. Because of that, also, you will develop ulcerations. So you have to rule out for vitamin. Always during the first cycle, chemotherapy have always myelosuppression. You will have to ensure the patient is having sufficient blood counts. Okay. Now you understood the severity of nausea and vomiting there. Now when you come to this thing, how you will counsel a patient with cisplatin? You'll usually tell you will have electrolyte imbalance, take in more water, but their mucositis and all will not be there. So you will just tell them the chance of that adverse effects of cisplatin. But when will you know how the patient or how the side effects are for a patient? How will you counsel a patient? Shagufta, tell me the intensity of counseling given for cisplatin for head and neck cancer and the intensity of counseling given to patient who is taking cisplatin with ovarian cancer. Is it the same?
No, ma'am.
No, right?
No, ma'am.
So, how should you counsel a patient? Based on the drug or based on the cancer or what else?
Ma'am, based on the cancer, ma'am.
Only based on cancer?
No, no, based on the drug what we are giving for the type of cancer they are having, ma'am.
Okay. It's a combination of what is the condition of the patient along with the treatment combined with the dose also. In radiation, you give it as a very small dose of cisplatin. So, for what is the intention? Curative, all this also will be there, okay? What is the intention behind chemotherapy? And cisplatin is highly nephrotoxic drug. You will also have to check the renal parameters of the patient. And you have to tell them about more and more oral intake. And because you will having more oral intake, there will be more urination. Because of electrolyte imbalance, you will have to counsel the patient to ensure that he do not have any electrolyte imbalance also. Because of less electrolytes, loss of appetite, he may have giddiness, sodium may follow. When sodium is low, you have chance of having seizures. So depending on how the patient is responding, you will have to counsel the patient. Whether it is weekly chemotherapy or whether it is 21 days, that also you will have to see. Guys, did you understand? Yes, ototoxicity is also there, but not for everyone. Guys, did you understand when I told you about mucositis? And when you tell about nausea, vomiting also, you have acute vomiting, delayed vomiting, anticipatory vomiting, all these things. So, you will have to choose the drugs based on which type of vomiting the patient has. Okay? Sometimes patient will have vomiting even during the administration of chemotherapy. Yes, highly emetogenic means more chance of causing vomiting. So you will have the intensity of anti-emetic agents that you use should be for highly emetogenic chemotherapy like NK1 antagonist and all this. Okay. Ondansetron for low emetogenic you can give. When you are giving high emetogenic chemotherapy, you will give aprepitant, fosaprepitant, Akynzeo. It's a combination of palnositron and nutipitant. All these drugs you will be giving to the patient depending on the sensitivity of the patient, like all this, and also the emetogenicity of chemotherapy. Hope you have understood. And mucositis also. Guys, another thing I will tell you. Another two conditions I will give you. Okay, managing mucositis in a patient where the patient is of head and neck cancer is on cisplatin, and managing mucositis in case of bone marrow transplants. In bone marrow transplants, patients will have, very what kind, like severity of mucositis will be high because of low blood counts, all these things, patient is susceptible to infections. You will be prescribing them with chlorhexidine mouthwash, Clogen lozenges, or Clogen lozenges are nothing but cotrimoxazole, 10 mg, to prevent the fungal infections in mouth. And the mucositis is very high in bone marrow transplant cases. In that case, you will be requiring xylocaine gel. Here, Zytizel and all would be sufficient. Okay, for local application and all this. If you take hydrate, folate, all this, if you substitute, it will be fine. But in case of bone marrow transplants and all, the severity of mucositis is very high. Even not a drop of water will not be able to, can be sipped by the patients. Now you understand the intent. You just can't tell these are the drugs used for mucositis. This drug should be given for mucositis. It is not fixed. Okay? It depending on the choice of drug always depends on the type of patient, intensity of the adverse effects, and what kind of patient you are treating, and how aggressively you should treat. Okay? Guys, did you understand this? In case of head and neck cancer and all, you can put a Ryle's tube and then you can give some feeds and all to the patient, okay? But in case of BMT, you will have to hydrate the patient in IV. IV hydration have to be given. Sometimes total parenteral nutrition have to be given to patient. It goes to that severity sometimes that a patient cannot tolerate mucositis. Okay? You understood? Hope you have understood this. Even the nausea and vomiting is also like that. Depending on type of vomit, some people will not face any vomiting. So non-pharmacologically, I told you, see, depending on that, see, that is why we have something called as grading of toxicities. If you can go and download, CTCAE grading version 1.5, sorry, version 5, you will be able to see all the grades of all the adverse effects. So how you will have to take a call depending on the grade. Have you understood where do you use grading of toxicities? How aggressively you should treat a patient depends on the grading of toxicities. You see here, grade 1 here you can see here, painless ulcer, erythema or mild soreness, can drink, can eat and drink, no intervention is required. Moderate pain, modified diet is indicated. When there is severe pain, when it is interfering with oral intake, how you should treat a patient. When life-threatening consequences, like in BMT and all, you have to give IV, and then you have to give local anesthetic agents to the patient at least to tolerate the pain. Okay? To ensure that his sleep is not disturbed. And anorexia, how do you treat? You have that hormonal agents, okay? Something called megestrol acetate. Okay? Megestrol acetate, you will give to a patient. That will, many patients there'll be 80 mg, 160 mg tablets. Okay? It's nothing but a progestin. It's a synthetic progestin, okay? So it will stimulate the appetite. Like cancer, cachexia, cancer, weight loss, and all these things, you will have so much of, you need you need appetite stimulants. So at this time, you will give this megestrol acetate, which is a synthetic progestin. Okay? It will be beneficial in patients who have very severe weight loss. Okay? It is also used in breast cancer and endometrial cancer. Okay? So, and dosage and all this, some people 80 mg, some people 160 mg. So, how many months you want to treat depending on the type of condition. Another thing is, you are asking about newborn injection. Here we have something that when a patient comes for the first time, we usually give multivitamin and B12 injection for the first time. And consequently, when the patient is coming, like a pre-hydration before starting of chemotherapy or pre-medications, we go on with 1 ampule MVI and 1000 microgram of vitamin B12 for the patients to so that they every 21 days, even if their appetite is good or not, we usually give 1 500 ml NS, we give this one for a patient. Okay. Just because you're giving vitamins will not increase the weight, just a supplement for the support for the production of blood cells. Okay, we usually give in every regimen to a patient. And if patient is very fit and fine, we don't go for giving multivitamins. Okay. So this is how you will treat loss of appetite for a patient. And I told you about antiemetics also. You can go through antiemetics, different kind of antiemetics that will be there. And choice is depending on the type of chemotherapy, okay? Like 5-HT3 receptor antagonists like ondansetron, all these things. See, granisetron is usually given within some hospitals as pre-medication. Ondansetron is a drug that will be given for preventing vomiting, after chemotherapy in discharge medications, usually 8 mg TID. Usually metoclopramide and all this we don't use in discharge medications in most of our setting. Like fosaprepitant, aprepitant that we use for the patient. Nutipitant and palnosatron combination also we use. Dexamethasone, that is also, it's a corticosteroid that will be used in most of the pre-medication to prevent vomiting and also hypersensitivity reactions. Okay. Cannabinoids and all we don't use in Indian settings. We only use NK1 receptor antagonist 5-HT3 and corticosteroids in combination of pre-medications and also when you give them as supportive care medications in discharge. Okay. Did you understand till here, guys? Olanzapine is usually we don't give in to all the patients. Olanzapine 2.5 mg for 3 days. Olanzapine 5 mg is given for 5 days in some patients to prevent the delayed vomiting in patients. Okay. Olanzapine, depending on the type of patient we prescribe. But there is something you should not give for every patient olanzapine. It is not required. Suppose if what I've seen, some of our physicians give olanzapine to few patients which have for highly hematogenic chemotherapy. But some physicians usually stop with ondansetron. They will watch during the first cycle, and depending on if patient requiring, then they'll add olanzapine. But usually we don't add of olanzapine for every patient. But adding an olanzapine is an additional benefit. But unnecessarily, you should not add on any supportive care medications to a patient. Clear? Any other doubts till here? This is how you have to intervene a patient, okay? That is how you will provide your suggestions. Next one, what is there? We finish nausea, we finish vomiting. These are the common things. Mucositis, anorexia, I told you. Another thing is, we'll talk about myelosuppression. Myelosuppression is, why do you see? Okay, whom else I called you? I'll call one of you. Anirudh, unmute.
Yes, ma'am.
Tell me, where do you see this myelosuppression?
Ma'am, in case of HIV,
We're talking about cancer, dear. We see with most of the anti-cancer drugs like adriamycin, you will see docetaxel, paclitaxel, carboplatin. Yes or no?
Yes, ma'am.
Yes, thiotipsy you will see in most of the anti-cancer drugs, you will have chance of myelosuppression. Okay. So wherever you have myelosuppression, mainly you will see in hematological cancers, and also people who are on adriamycin, that's what doxorubicin, daunorubicin, paclitaxel, docetaxel, carboplatin, and also other drugs also you will see this one. So in some combination regimens, yes. So in combination regimens, and when you are giving R-CHOP, and when you are giving R-CHOP, in lymphomas and all, what you will see, you will have more chance of myelosuppression. That's why you will give GCSF, PEG GCSF. PEG GCSF will be 6 mg subcutaneous once 24 hours after chemotherapy. If it is GCSF 300 microgram, you can use it for prolonged period. You have to give colony stimulating factors so that it will stimulate your bone marrow to produce WBC in all the patients who are having risk of myelosuppression. Okay. Another question is, suppose patient is diabetic and patient is on paclitaxel. What do you think? What you should do? Yes. Deepinder, you asked me one question. Ma'am, what is the difference between GCSF and PEG GCSF? See, both are colony stimulating factors. The dose of PEG GCSF is 6 microgram. Okay, subcutaneous. GCSF is 6 mg is PEG GCSF. GCSF is 300 microgram. Okay, yes, 300 microgram and 6 mg. 300 microgram, why you are giving is patient after this R-CHOP, you need to slowly stimulate the bone marrow because the intensity of adverse effects is very high in hematological cancers. PEG GCSF, if you give one injection would be sufficient. 300 microgram, when you want to give a prolonged period, you want to stimulate bone marrow, you will decide that. Okay. And when you give ifosfamide cisplatin also, we will give this colony stimulating factors. And people who want to donate granulocytes, for them also we will give 300 microgram to a patient, to a donor, along with one dexamethasone. And then we'll ask the patient to wait for 8 hours and then go for donation so that so much of WBC will be generated, granulocytes. WBC are granulocytes and agranulocytes. When the patient in BMT and all these require granulocytes who have very low WBC count, when the donor also you will give 300 microgram only. Hyperglycemia leading to diabetic neuropathy with paclitaxel. Anirudh, I will tell you. That's what I was telling you. If patient is a diabetic who is uncontrolled, the neuropathy chances or the intensity of neuropathy with paclitaxel would be high. The chances would be high. I won't tell would be high. The chances would be high. And the neuropathy with oxaliplatin also would be high. That is why in discharge medication during chemotherapy, you will prescribe with Benadon. Okay? For a patient. Clear, Anirudh? Depending on the
Yes,
type of
ma'am.
adverse
Yes.
effect, you will prescribe discharge medication. See, with paclitaxel, you will have neuropathy. You know, the chance of body pains also is very high with taxanes. You will prescribe Ultracet and tablet Dolo to a patient. When patient will start complaining about, pricking pain, in case pricking pain, you will watch for the first cycle. If the intensity is severe, in the feet and all, if the intensity of pain is severe, for some patients, they'll go for dose reduction of paclitaxel, or some patients, you will change the paclitaxel formulation to Pacli Aqualip formulation, because Aqualip formulation, the dose will not change. For Aqualip and Taxel, the dose is same, but the formulation is different, and the adverse effects and severity of adverse effects is also very less. And for paclitaxel administration, you will require codon set. And for paclitaxel, you will not require anything. Clear, Anirudh? Other guys, anybody, any doubts still here?
Yes, ma'am.
Clear? And people, if they're having paclitaxel neuropathy, you will go with pregabalin 75 mg or GABA NT 400 mg in some patients. If ultraset does not work, what is the common adverse effects of ultraset, guys? Anybody?
Drowsiness, ma'am.
Drowsiness.
Ma'am, constipation.
Very good. Constipation. Suppose there is some drug called gemcitabine. Okay. When you are giving for in some urothelial cancers and all, when you're giving gemcitabine cisplatin, most of the patients will start complaining about constipation. Not only having gemcitabine, the side effect is constipation. They'll have in discharge medications for pain. You will be prescribing Ultraset for a patient. And so the intensity of constipation would be high for a patient. And you will have to prescribe it, cremofen syrup for preventing constipation. Okay. Now you understood, guys, how the intensity of side effects will increase, how you will have to monitor a patient, and how you will have to counsel them, about having, about what, having more fiber intake, ensure that his digestion is good. He have to increase, and suppose patient is having loose motion, loose stools or diarrhea. What you would tell a patient? You are telling patients to eat so much of good food, protein supplements, all these things, fiber food, all this. Patient is having loose stool, something like irinotecan and all. You will be giving atropine as a pre-medication. And you will be prescribing patient with anti-diarrhea like Lomotil. All this you will be prescribing to a patient. Yeah, loperamide. That's what. Loperamide you will be that 2 mg SOS that after 3 loose stools, every 4 hours you can take one, or after every 3 to 4 episodes of loose stools, you can take one. You will tell a patient. But what additional things that you should tell Dipender? Tell me. Interactive, and ma'am is only talking. She's not asking any questions.
Ma'am, we'll say the patient, when we consult the patient, we usually say that to take ORS and Sporolac, but loperamide we use in the end when it is 6 to 7 times, and I usually ask patient to come in emergency only in these situations and not to take loperamide first.
No, 6 to 7 times. After 3 times only, you should take one loperamide. Because
Yes, ma'am.
before he
That
comes to emergency, it will be severely. I want something additional intervention, guys. What additionally you will counsel the patient before going after first cycle? Come on, think. I already given the answer when I'm explaining. Think. Anyone? Come on, guys. I'm feeling bored of teaching from one side. Anish, Divesh. See, these guys are not in class, sir. Anish, see, Anish is not in class. Anish, you're in class?
ma'am, during the consent, we also ask the patient it because patient are very keen to they always say that we want some medications, pre-medications. They don't know what the side effects will be, but they want medications priorly, and then we ask patient that the toxicities depend upon their tolerance also.
No. I am telling you from your side one additional thing that you'll have to tell a patient. Non-pharmacological thing. I just told you. What will dietitian tell? Take good protein food, take eggs, egg whites.
Yes, ma'am.
What will protein do? Huh? Tell me no. What will protein do? It will increase the diarrhea, yes or not? Anish. Anish. Tell me, Anish. Anish, tell me. I want to listen. No certificate for if you're not answering. He is not listening, class. So, guys, I'm taking this much efforts to teach you. If you are not listening, no certificates, no concern. I'll not allow you to get certificates without exam. Neelima, Neelima, unmute your mic.
Yes, ma'am.
Tell me.
Ma'am, can you please repeat the question?
What additional non-pharmacological counsel? I won't ask you question. What did I tell you just before? Tell me.
A protein diet which increases diarrhea, is just something like this.
Not something like this. That don't change at all.
Yes, ma'am.
So when patient is susceptible to loose stools, what you will tell them? Avoid protein powders and also something like egg when they have diarrhea. Yes or no?
Yes, ma'am.
And you'll
And
ask them
even
to eat
dairy
what
products
kind of
also.
food? Yes. Milk products you will tell to avoid, but
Yeah.
tell them to have yogurt,
Yeah, yes, ma'am.
sporlac, yogurt, all this. Yes or no?
Yes,
Firstly,
ma'am.
you not go with antibiotics. And you'll tell them to have some electrolytes. Yes or no?
Mm.
Because of so much of loose stools, patient will have electrolyte imbalance.
Imbalance.
Anish, see this guy is muting, unmuting. He's not telling me answers. Megha,
Yes, ma'am.
oh, she's there. Okay. You understood, right? If I'm having, see, if suppose one patient is having so much of, nausea, patient is not able to take food. She comes and complains you. See, Megha, I cannot eat my food. It's very difficult for me. I feel so much nauseatic after my chemotherapy. So what should I do? So I will ask Megha. She'll explain you. Megha, now tell me what you'll do. What you'll tell. Tell me, dear, how will you
Ma'am.
counsel a patient?
Mm,
Simple points. Try out.
Uh, antiemetics, ma'am.
Okay, first thing is you'll ask them whether did you.
Have they taken like any antiemetics to?
Okay, you'll ask them whether have you been taking the prescribed discharge
And
medications correctly. Yes or no?
yes, ma'am.
So if patient is telling I did not take, then you will think okay, patient did not take. That is the reason. Maybe he is having nausea. You will tell them from next time. Please do
Take
take.
the prescribed medicine
Because
regularly.
of nausea, patient will not be able to eat food, right?
Yes, ma'am.
So at that time, what you will tell?
First, we'll ask the patient to take the medicine regularly,
Hmm.
so that the nausea will be in control and they can have proper diet.
Okay. Still, so how you will tell them to eat food?
I didn't get it, ma'am.
Okay. There is nausea in spite of, even in spite of even you telling them to take adhering to medication. So adherence is good, ma.
Yeah, ma'am.
What additional counseling you will give to the patient?
Additional count.
Means what else you will tell? See, because of nausea, we will not be able to eat food.
Yes, ma'am.
In that case, what you will tell?
Fluid content they can increase, ma'am.
Huh?
Increase in fluid intake increase.
So small fluid you will tell them to take so that there is that no need to chew and all, somehow some energy will go.
Yes, ma'am.
What is another additional point?
No idea, ma'am.
Simple, ma. No need to think so much. See, I will tell you what is the simple thing is when patients are not able to eat. See, you have read about fats, proteins, carbohydrates, all of you. Mega,
Yes,
yes
ma'am.
or no?
Yes, ma'am.
So have you ever observed if you're eating a biryani, immediately you will have some space to eat ice cream, yes or no?
Yes, ma'am.
Suppose you're going to Taco Bell. All of you, just not Mega. After you Taco Bell, do you feel like eating ice cream?
Yes, ma'am.
Yes, sir. Okay. What is the quantity of food that you will have in Taco Bell? Will it differ from the quantity of biryani? Biryani more than half you can eat. Can you eat the same quantity of cheese?
No, ma'am.
Why?
Ma'am,
Are you?
because cheese feels heavy. Like
Yes.
you can't have so much.
But you are more energetic, right, with cheese?
Mm.
Yes or no? For longer
Yes,
time you are
ma'am.
full, right?
Yes, yes, ma'am.
But with biryani you are not full longer time. If you have biryani in lunch, night again dinner, second biryani you can have. Yes or no?
Yes, ma'am.
Why? Because carbohydrates, they get digested very fast. But fats will give you more energy and the digestion will take longer time. So if patient is having nausea, you have to give less food with more energy. Understood?
Yes, ma'am.
When there is no chance of loose stools, you will supplement with protein powders. So one scoop of protein powder will give around 24 grams of protein. So protein is highly energetic. You will not fall sick. The quantity of food is less. So for patients whose appetite is not good, you will tell them eat yogurt. Yogurt will give you 6 grams of protein. Just is 2 spoons of Greek yogurt. So you always have to choose foods that are highly energetic and also very less intake is there with that drugs. Understood, guys? Understood? Yes or no? Arfa? Arfa? Tell me, did you understand? Arfa, tell me. Come on, you unmuted the mic. Speak out. Why she is not talking? Bisha, Dr. Bisha. She is also not there. Himanshu,
Ma'am,
tell me, is it that for everybody who is not able,
ma'am, your voice is not audible. Sometime I
now it's
message you.
audible?
Hello.
Now is it audible? Am I audible now? Am I audible, guys? Yes or no? Please reply.
Yes, ma'am.
Why they're not able to? Arfa, tell me.
Ma'am, I have listened to it. I couldn't unmute the mic because of the settings, ma'am.
Okay, now is it okay?
Yes, ma'am. Yes, ma'am.
Yeah, tell me.
I have understood the concept, ma'am.
No, I'm asking you. For every patient who is having loss of appetite, should you give megestrol acetate for a patient?
No, ma'am. It can't
Not
be given.
required, right?
No.
So you have to suggest all the possible ways. Even after that, if you are having severe weight loss and cachexia, then you should go for megestrol acetate like supplements. Okay.
Yes, ma'am. Only for severe cases can be given because magistrol acetate in long term can cause other side effects.
Yes, always you should try to. I think you're going to have conference next week. De-prescribing is there in different this thing, right? Next is Sunday. De-prescribing in oncology. You have a topic. Yes or no? You have 1 day conference. You have some concepts of de-prescribing there. And for patients, see, that I will tell you another case scenario. Usually, you will not have long-term chemotherapy for a patient. Suppose in breast cancer and all. Himanshu, is my voice clear now? Can you hear me?
Yes, ma'am.
Okay. See,
Ma'am, actually, here heavy rain, so network issue, ma'am.
okay, no problem. So when patients, sometimes, what will happen is that the DMOs or doctors, usually they keep transcribing the discharge medication, they keep adding and subtracting. And for some people on immunotherapy and all, they'll put ondansetron SOS as a flow that they put for chemotherapy. But do you think for everybody, do you require 7 days of ondem? Tell me, Himanshu.
Sorry, ma'am.
After first cycle of chemotherapy, in first cycle, you have advised for the patient to take 5 days of ondansetron,
Yes,
8
ma'am.
mg TID before food. But when patient came for second cycle, you will go and ask him, sir, do you have any problems? Did you face any side effects? How was your appetite? How is your digestion? How is your intake? Overall, do you have any fatigue? How do you are feeling? You ask all these questions to a patient, and patient says that he didn't have any nausea or vomiting, anything. He was very well fine. What kind of call would you take in his second discharge supportive medications?
Like, ma'am, PPIs, okay, and
Hmm?
antiemetics drug and PRN schedule. We give.
So you can tell that what you can do is for first, if you're putting for 5 days, you can reduce it to 3 days because you don't know. First cycle, he may not have vomiting, but second
Yes, ma'am.
cycle may not be possible. So you will make the period, 3 days, or you can tell them take it for 1 day and next day, if the patient will feel nauseatic, then take it. If
Yes.
feel on the first day nauseatic, then he should take on full first day. Second day, if he feels, he can take. If he's not feeling, he can stop. Okay?
Okay. Okay.
Like that, you can suggest to a patient.
Okay.
If suppose patient will complain of severity of vomiting in spite of, even if he is taking antiemetics, then somebody was asking about olanzapine. Some people will have Dexa for MGBD for 3 days. Like
Yes,
this
ma'am.
will be added in their discharge medications.
Yes, ma'am.
Clear, guys?
Yes, ma'am.
Okay. If you think the patient is having more severity of myelosuppression, what kind of strategies that you will suggest a patient? The severity of myelosuppression will lead to infection. So in such kind of patients, what kind of interventions or strategies do you suggest the patient? Tell me. Again, should I call? Lokesh.
Ma'am, can you repeat the question?
Okay. You know, certain drugs will cause myelosuppression. Myelosuppression means decrease in bone marrow count, whether it is RBC, WBC, or anything. And you know, myelosuppression will have more chance of patient having infection. So, in that case, what do you suggest strategies to prevent infection in patients?
Ma'am, not to go on crowded places and avoid contact with the sick people and
Mhm. Tell me.
Ma'am, maybe starting with antibiotics,
Why to start on antibiotics? I told you strategies to prevent infection in
ma'am.
patients who are suspected with.
Like prevention, like we can do,
Hmm?
like prevention we can give antibiotics.
Why you want to give antibiotics simply to a patient?
For prophylaxis,
Why you want to give prophylactic antibiotics simply?
like if there's a risk of infection, no, ma'am.
Risk is there. But I told you is chance of susceptibility. Should avoid first aid. Why you want to give antibiotics simply? It's additional cost. Simple man, wear mask. She was telling no, wear mask. Sanitize your hands. Another thing is when you're suggesting about food, you should tell them not to use or anything raw or uncooked. Basic things. You should tell them to have freshly cooked food. Correct or not?
Yes, ma'am.
You should have some soft diet, freshly cooked food. Avoid crowds. Hygiene is very important. All these things. Okay. And should always keep away from kids also, elderly people also. Because the chance of infection would be high. And the washroom should not be same. Okay. Basic things. And you should understand if you get burning micturition, when you should hydrate well. You know, hydration is very important. So you should tell them hydrate well. You should educate them about signs of fever. If they have fever and all, immediately they should come to the hospital. You should explain them about all these things. Okay. And depending on type of cancer, if patient is having lung cancer, so how you counsel a patient would be entirely different. You should not get exposed to smoke, all these things. Understood, guys? Another one is hypersensitivity reactions. You know, in pre-med, why do you think there will be hypersensitivity reactions with targeted therapies and immunotherapies? Tell me one of you. Have you ever listened? Trastuzumab, Rituximab, Adalimumab, Zumab, Mumab, Umab. Okay. Immune system gets accelerated during immunotherapies. Yes. Have you heard? Listen to me clearly.
Yes, ma'am.
Mumab, Zumab, Momab. Can't, don't think so much, huh? Wait. Because,
Monoclonal antibodies, ma'am.
yes, these difference. Zumab, Mumab, Momab. Why means some are from human source, some are from murine source. Understood? When something is coming from animal source, definitely you will have chance of hypersensitivity reaction. Yes or no?
Yes, ma'am.
So, when the drug is made from human source, the chance of adverse effects will be less. When the drug is prepared from murine source or any other source, the chance of hypersensitivity reactions is high. That is why when you are giving these drugs which have more, like targeted therapies and all, they act on immune system, okay? And then they'll start producing hypersensitivity reactions. Different patients will have different symptoms for hypersensitivity. Some will have chills, some will have, fever, some will have less blood pressure, SpO2 changes will come, itching will come, rashes will come. It can be seen in any way. So, and for such kind of drugs, how do you manage hypersensitivity is when you want to start a drug, immediately you will have anyhow pre-medications like, for rituximab, one paracetamol, one Avil you will have. Okay, and then you will start with the MAB. Here, usually you don't use corticosteroids. With immunotherapies and also, you don't use corticosteroids because the effect of immunotherapy will decrease when you use steroids. You can read there some articles. Okay, but when in these cases, you will give Avil, one paracetamol, and then you will start off the drug. And sometimes you give, hydrocortisone with MABs, Avil and hydrocortisone. Even with zoledronic acid also you will give. So you'll give paracetamol, you'll start the drug. You will start at a very slow rate. You will desensitize the patient. So if you give drug at a time, the chance or intensity of adverse effects will be more. So you will give very little amount of drug at a very slow rate. Slowly you keep tapering or increasing the rate by observing the patient. You will have to administer the drug through the infusion pumps. So when you get a hypersensitivity reaction, the first thing is what you will have to do. You will stop the infusion. You will disconnect the infusion and then you will start Evil. You will give them Evil and hydrocot IV push. Usually you will give one Evil injection. If does not subside, then you will go for hydrocortisone. In most of the cases, you will give for both Evil and hydrocortisone. Sometimes we have tried out avoiding hydrocortisone for hypersensitivity reactions depending on severity. We just gave one Evil. If patient had vomiting episode, we gave one on them and we used to observe the patient for some time by stopping the infusion. Okay. In some practice, what will happen is some people will be getting Evil through 100 ml NS. So in the same thing, the people will think that, okay, even during hypersensitivity, I have to give Evil for half an hour. No, when hypersensitivity reaction comes and all, you have to give Evil, one ampule, IV push to a patient. So you understand how you will have to give either when you give it as a pre-medication, you can give it as IV push. Some patients we dilute in 10 ml, some people usually give in 100 ml NS. Okay, now you understood how you have to give a drug. Yes or no, how you have to use Evil injection. Understood, guys? That's how usually you manage hypersensitivity reactions. Sometimes people would be having chills and all. It will take some half an hour sometimes. At the time when you restart, you should restart very slowly. Sometimes, there's a case where a patient is being treated for non-Hodgkin's lymphoma. Patient was started on rituximab injection. Patient had hypersensitivity reactions. And then doctor have advised give an ampule evil. Give injection. Doctor has advised give injection evil to the patient. It means that sister did not understand that she will have to, give IV push. What she did, she went and corrected evil in 100 ml NS. Okay, irrespective of anything, she connected evil. That is okay. But immediately again, patient developed reaction. Can anybody tell me why did patient develop reaction? Come on, guys, come on. If somebody tell this, very good gift. Patient was started on rituximab infusion as a part of R-CHOP protocol, and patient had hypersensitivity after 10 minutes of the start of infusion. Doctor advised the nursing staff to give 1 ampule injection evil to the patient. Okay. Then the nurse started on 1 ampule in 100 ml NS IV to the patient. And immediately within not even 30 seconds or not even like very few, like very within a minute, patient developed again chills and, started, like having hypersensitivity reaction. Why do you think so? Patient had hypersensitivity reaction. Yes, did you understand? Guys,
Yes,
come on,
yes,
guys.
ma'am.
Tell me. Tell me, dear, tell me. I'm waiting to hear. One of you at least. After telling the answer, don't tell. Anirudh, somewhere near. Not fluoride, dear. I'll give you 1 more minute. Think, think, think. Think smart. Arey, Mubashir, I'm telling you.
Ma'am,
It is
Is
evil
it
only.
urine divide?
ma'am, did
Huh?
Is
the
it urine divide? So that's why.
Think, think, think. Very small, smart answer.
ma'am did the I will is I will in infusion is giving through the drug already administering.
Evil, physician told to connect injection. I will give 1 injection. I will. Sister reconstituted Evil in 100 ml NS and she connected. And immediately after connecting, within few seconds, patient developed hypersensitivity reaction second time. Why so? I'll tell. If I tell, all of you are transferring me 1 chocolate. Huh?
Delusion, 1 pure delusion in 100 ml NS.
Yeah, you can give it like that
Ma'am,
also.
Ma'am,
ma'am
there
she
was cytokine reaction. There was
Okay,
cytokine reaction, and the infusion was given
ma'am she
way
didn't stop the medication
restarted
already
quickly.
administering.
She stopped, man. She's not giving any rituximab.
Okay, okay.
She took the drip set. She connected it for Evil.
Ma'am, earlier also it was given, but it doesn't work. Then something else should be given.
Evil did
Cytokine
not go
reaction.
completely also. Just the infusion started, patient developed reaction.
Ma'am, cytokine reaction again occurred as the avil was restarted soon after the
You
hypersensitivity.
you should give Evil immediately so that the hypersensitivity reaction will not come. The treatment for hypersensitivity is Evil. But why did patient develop hypersensitivity again? I have intervened this, okay? Because of this, still the patient attender, still they remind, they keep me in brain. They keep.
Ma'am, rituximab can cause histamine release and the evil is antihistamine, ma'am.
Yes, man. I will tell you now, guys. I told you she removed the drip set and she connected the drip set to Evil, okay? But already in the drip set, what is there? Rituximab is there, yes or no?
Yes, ma'am. It is well sir. How?
It's not Evil injection because already some ml of rituximab is there in the drip set, right? You remove the drip set, connected with Evil means what? What went inside your body is not Evil. What went inside the patient's
Rituximab.
body is rituximab.
Rituximab.
Understood?
Yes, ma'am.
What happened? I'll tell you the case. What happened? The patient was started on rituximab at night and they observed the reaction morning full patient was shivering in the ward. When I went, then I asked what happened, what happened. Then I told sister, did you give Evil injection? Yes, ma'am, I connected Evil injection. And then patient developed hypersensitivity reaction. And attender was telling me, madam, Evil also caused me hypersensitivity reaction. I think Evil did not work. See, if Evil would have not worked for the patient before starting rituximab, did we give in pre-medication Evil or not to the patient? Come on, guys. We
Yes,
gave,
we need to
right?
give pre-medication. Yeah.
When we gave, patient did not have any reaction, right?
Yes.
And how will patient develop a reaction with Evil when it was started second time? No, right? Understood, guys? Think out of the box. So then I just told, see, how would Evil cause you? It would have given you like this also. Then I told, okay, immediately it developed means what will be there in the drip set? Then I saw there is only one drip set connected. There was no second drip set in the. Then I saw, okay, somewhere something is wrong. Then I could understand. Then I asked them to give Evil IV push. And then we started off in rituximab injection and then successfully it went. And I explained the whole scenario to the patient. Literally, they were shivering. Now patient's attender is my friend. Did you guys understand where you have to think? Immediately you have to not to take a call on. See, if something would have happened like this, lifelong patient will be thinking I'm allergic to Evil. Yes or no? Understood how to think? Think out of the box. Anish, don't tell yes and no. You didn't tell me answers today. Understood, guys? So you have to keep working and analyzing stuff. Do you find oncology is interesting when you get such type of stuff? Okay, okay, Anish. Next class. Understood, guys?
Yes, ma'am.
Which class is better? Discussion or, with screen one-side teaching?
Discussion, ma'am.
Case studies are good, no? You people are understanding how to think when I am telling? Okay, another one I will ask. Patient is having very thin veins. Okay, and you are giving drugs to the patient through a peripheral line. And you are giving some drugs which are having so much of extravasation. So, they will tell you give through running NS and all. Suppose when you want to prevent extravasations or when you want to prevent leakage of the drugs, what you should do? Simple is after all chemotherapy, you should ask the nursing staff to give 100 ml NS flush. Flush means very fast so that it will wash off all the veins. So the chance of extravasations will be less. These all are small preventive measures. See, oncology doesn't mean you'll read the adverse effects, go and explain and discharge medication. You should be able to predict the adverse drug reactions of the patient. Depending on if the patient is having constipation after first cycle, you have to give good non-pharmacological and pharmacological counseling on how to avoid constipation. If he is having nausea, vomiting, how you will have to counsel to ensure Either severity should not happen or it should be prevented. That is how you have to think on managing adverse effects of chemotherapy. Okay. Next class, we'll be learning how to report adverse drug reactions, all case studies in a ADR form. So guys, you have ADR scales in your group, okay, in this oncology group. Do you find that PDF or not? I'll tell you how to intervene adverse drug reactions in next class. Hands-on, we will do it. I want all of you to have ADR version 1.5 form with you. And also I want all of you to take print of these scales with you and keep ready. And I want you to go through these scales, each and every line. Okay, sorry, 1.4. CTCA is version 5, sorry. It's 1.4. Very good, Yash. I like when people correct me when I make mistakes. That means you are attentive. I am also a good teacher. Yes or no? Yes, no? Am I good or bad? If you are
Good teacher, ma'am.
good teacher only. Thank you, man. Sometimes I will also, feel very good when I listen like this. When I am good, when you people answer it well. Thank you, thank you. So we should have some group discussions like this so that we will revise. Suppose, see, I will tell you one more. Okay. Madam is good, no? Madam will ask another question. If the patient is taking the similar drug and if the patient, the stage of cancer is, stage 4 or something. So what would be very less? His immunity would be very less. So the chance of infection is very high. You understood? And when I told you about dose-dense chemotherapy, dose-intense chemotherapy, where you will decrease the intervals depending on how fast the cells are growing. K67 index, proliferative index. How fast tumor is growing means more cells are growing, more you are giving chemotherapy to a patient, very less frequency. So what will happen? More chance of adverse effects. So the intensity of adverse effects would be high and the utmost care you will have to take. Understood? The severity of adverse effects also will change. You can think like this, no? I'm not seeing any of your learnings in LinkedIn, man. For everything you will tell yes, yes, yes. Share your knowledge. Write at least one sentence that you have learned in the class in LinkedIn. Post it. Post some intervention. Post some adverse effects. Read something. Create something. Time pass 5 minutes. LinkedIn. That is a good contribution for my teaching and your learning and sharing your knowledge. You post something, at least this 20 people will read that. You tag Ajit sir, you tag me, you tag Klimet. So many more people will read. Somebody, Himanshu is writing something. Dipinder is writing something. They have learned something. That one sentence, people will remember. At least start sharing your knowledge. Okay. Get good reach. Let people come to know you are learning oncology. Learn something about some drug. Learn something about some case. Learn some. See, when you tell about 5FU, infusion related reactions, injection related reactions, both are different. Why there is blackish discoloration of hands and feet? See, now nobody is responding. Yes or no? Post at least in our WhatsApp group something. People will learn. Tomorrow I want to see some learning in the group. I also
Sure,
want to
ma'am.
learn.
I will do. I will start the first step, ma'am.
Yes. Read one point every day. Start. I've given you some questions, no? Shagufta only. I've shared some questions. Whom did I share?
Ma'am, a few sets are left, ma'am. You haven't given that set 5, 6, and 7. That questions you
No,
haven't given, ma'am.
I will give you today, but today I will give you. Please text me
Okay,
one
ma'am.
text. Then I will give you questions, guys. You people start learning. I don't want any PPT. Type the question, type the answer, and send it in the group. At least like that you will study. For those questions, post on LinkedIn. You message me. I will read it. I will approve it. Once I approve, please post that question on LinkedIn. Okay?
Okay, ma'am.
At least some learning you will get. No, don't think what to post. Post the answers for all these questions. Read the articles, prepare the answer, send it in the group. I'll approve, and then you can post it. Enough for today.
Yes, ma'am.
So next class we'll be discussing about pharmacovigilance in oncology. So many case studies. It would be a master class of 2 hours or something, where so many people will come. But still, I want my students to answer. Little bit of selfishness. Whatever you think. Okay. Good night then. Hope any doubts, guys, in this class. Okay, then if you have anything, post it in the group. Good night. Guys, I wanted to ask you something. What about having a chemotherapy module of 1 week, wherein which you will learn about dosage calculations, vials, different formulations, guidelines, how to write policies for chemotherapy, what all to monitor. What do you think of having such a module? If you work as a clinical pharmacist, you want to develop your guidelines, hands-on training. How would you all love it? It would be nice. You people can share it in your call. I just got an idea. Like how you people, as a practicing clinical pharmacist, will be able to write policies of chemotherapy in the hospital. Prepare guidelines for chemotherapy. We'll start off a simple workshop. I cannot, means not in the extent of NABH policy right now. At least a chemotherapy policy you will be writing for a hospital. Maybe an NABH policy, a complete policy of chemotherapy use in a hospital. How would you appreciate having that? Till now we haven't taken it. It will be helpful for all the clinical pharmacists. If so, I shared my idea. Get to see how many students are interested to join, maybe in your college, in your friends and all this. I will plan to design that course, like continuously, not like weekly once. A pack of 3 days or pack of 5 days. In one single week, I'll finish the classes. Okay? Think about it. Ask your friends also. It's a group of large crowd. It would be very interesting when you start writing your policies. I will try designing it by next month. We'll have it. Okay? By the time you finish your modules, we'll start that short chemotherapy module. Okay? I'll help you write policies. I'll teach you. Okay then. Good night.